Hello, everyone. Thanks for joining. We will get started momentarily. Thanks for joining, everyone. We'll get started here in just a minute. All right, so good afternoon and good morning to everyone joining us today. Welcome to the December 2023 PQA Quality Forum webinar. My name is Amanda Ryan. I'm Director of Education here at PQA, and our topic for our Quality Forum this month is the 2023 PQS Trend Report in Pharmacy Quality. This webinar is sponsored by PQS. PQA is grateful for PQS's support today and throughout the year. And if you would like to find out more about PQS, you can do so by visiting pharmacyquality.com. Before we get started, I'd like to walk you quickly through our usual housekeeping items here. First, you can submit your questions to us using the Q&A feature that you see at the bottom of your screen there. Feel free to do that throughout the presentation, and we will have some time for the Q&A at the end of the webinar today. Additionally, the webinar recording and the slide deck will be both made available to PQA members in about a week from today's webinar, and that will be on the Member Resources Library section of the PQA website. We will also publish a recording of today's webinar on PQA's YouTube channel. And then finally, I always like to remind everyone to please complete the 1-minute survey that will populate as soon as the webinar ends today. We do use your feedback to help us design future programming. And now it's my pleasure to introduce you to our speaker for today's webinar. Andy Thorne is the Director of Analytics and Program Development at PQS. Andy has led the development of the trend report for the 2022 and 2023 reports, coordinating with both internal PQS team members as well as external groups to conceptualize the areas of focus for the report, to help determine the specific analyses to include and to complete those analyses as well as to draft and compile the report for its final release. Thanks, Andy, so much for joining us today. I will now turn the floor over to you.
Thanks, Amanda, and thank you to PQA for the opportunity to talk through this. This is a project that we shepherd through the year and always look forward to the publication. We'll say this at the very end as well. The report is available on our website at pharmacyquality.com. If you haven't seen it, feel free to go and download it from the website. Today we'll talk through the majority of the trend report. We won't get to touch on to everything that is in the trend report. There's also then further context that is in the report that I won't speak to today as well. So overall, I'll give some intro to what the trend report is, and then we will follow roughly the structure of the report itself, going through the introduction and background, giving some context on what are the questions that we asked and that led us to the specific analyses that were included. And that includes then things arranged around 2 general categories of socio-demographic factors and utilization factors that affect medication adherence. And then I'll wrap up with some final thoughts. So first off, what is the trend report? So the trend report was first published in 2019 from PQS, before my time with PQS. And leaders at PQS at the time identified that when we speak about things in medication use quality, we sometimes have our own languages. We have our own approach. And the trend report is an effort to try to contribute to the conversation and to create a more common and consistent language when we're talking about pharmacy trends or medication use quality, and make sure that we're keeping perspective of various stakeholders involved, specifically payers, pharmacies, and patients. And to that end, every other year, the trend report is focused specifically on the voice of payers, pharmacies, and patients. This year is different. So for the 2022 report, it was focused on those 3 areas for survey. This year, and as we did in 2021, we're looking more at targeted questions that we feel we can answer with the data sets that we have. The 2023 report is looking at factors that can affect or correlate with changes in medication adherence. So to that end, just to level set on medication adherence, and that it is important if you are here, if you are affiliated with PQA, this is likely nothing that I have to remind you of, but keep in mind that medications don't work if we don't take them. As a pharmacist, I have worked with patients who sometimes are on upwards of 20, 30 medications to help them with understanding their medications and making sure that they can be successful on all of the therapies that they are on. And yet then when I, as a relatively healthy person, sometimes have to take a medication 2 times a day or 3 times a day, I'm reminded how difficult it can be to fit that into a normal schedule when it's not something that you're used to in particular. So many of you may have felt this in your own lives as well. Adherence, we know it's important, but it is sometimes not the easiest thing for patients to achieve. For this report, we're going to be focusing on 3 what I often call core medication adherence measures: the proportion of days covered measures for statins, diabetes all class, and renin angiotensin system antagonists. I won't dwell on the details for these measures. I'm going to assume that the folks here on the webinar are reasonably familiar with these measures and their various medications that are included in the classes, but there is a little bit of a primer for that in the report and a reminder here for this slide. For the specific questions that we asked, the general overall theme is what is correlated with adherence. I should make a point here that all of this is not to establish a causal relationship. This is all descriptive observation research. We thought through what are the things that we can reasonably answer with the data that we have and data that is available and reliable for us. And how can we dig into different things that we may feel affect adherence? What are the patient factors that might affect the medication adherence, like socio-demographic status, or structural components that may correlate with better adherence or not, extended fills, or is there a difference between the channel through which patients receive their medications and the type of pharmacy that they might interact with? Or are there clinical factors, comorbidities, which we're using a little bit as a surrogate here for presence within the other measures that we're looking at? Or if they're taking multiple types of medication or one type of medication versus another in the particular case of diabetes PDC, where there are multiple drug classes included within the measure. We wanted to look to see where can we see differences? Where, when we do an analysis or a sub-analysis with these questions, and how can they lead us to deeper and deeper questions to ask? I also want to level set on the data set that we used. This is data that is in EQUIP, and the data for this report are provided to EQUIP from health plans and PBMs and do represent approximately 90% of Medicare lives. And the data used for the trend report is inclusive of 2022's calendar year and specifically limited to Medicare lives. I've got the counts here for the different patient populations that are in each of the measures. They range from just over 4 million patients that were included in these analyses for diabetes PDC to north of 13 million patients that were included for cholesterol PDC. This is a large data set. We felt that with this particular data set, we have a unique position and ability to be able to generate interesting results and interesting data off of this large of a data set. So with that, we'll start talking through some of the specific questions that we asked, how they were structured, and what the results were from those analyses. For socio-demographic factors, we focused in on age, gender, and economic status. And really, economic status, we're using a surrogate of low-income subsidy eligibility. There are many other socio-demographic factors that may be playing an effect in adherence. We felt that these were areas that we could dig into and potentially do sub-analyses across these factors to see of these categories, what do we see in this population? Starting with age, we found that for all measures, all of these 3 measures, they showed a higher mean age among adherent patients. And that difference ranges, well, I've got them in percent, but it should be a year here. It ranges from 0.7 years to 1 year, with the largest difference being seen in diabetes PDC. I will also call out the the majority of the patients, thankfully, for all of these measures were adherent, but that does not mean in any sense of that the non-adherent patient population was small. So interesting to see that we do see a difference in mean age in each measure, with higher mean age being correlated with adherent patients. Also within age, not only looking at the mean, we wanted to do stratification to see, is there a particular age group that does better than others, or where we see correlation with higher adherence. And for all of these measures, age less than 65 consistently showed the lowest adherence and the smallest population. Again, a reminder, this is limited only to Medicare lives. So not a surprise that the age less than 65 category ended up being the smallest. The largest category was age 65 through 74. And for some measures, that was the highest adherence age stratum. For others, it was not. And then we also see for diabetes PDC that it's the same between the age 65 to 74 and age 75 plus. Again, we've given the population numbers here. These are large populations, and we see it, in this case, mostly relatively small differences between the rates in these age stratum. The difference between age less than 65 is more than the difference between age 65 and 74 and age 75 plus. Moving on to gender, we found in our results that bucking possible stereotypes, male Medicare populations tended to have generally higher medication adherence. The difference here is also not enormous. These are certainly statistically significant because of the large sample size, but we've got a 1% difference for cholesterol PDC, diabetes PDC at 1.5%, and then RASA PDC is the other direction, but it's a relatively small difference between comparing the adherence of female patients and male patients in this data set. Moving on to economic status, I did call out that we're using a surrogate here. General economic status data other than low-income subsidy, we didn't feel was going to be accessible enough to us. But using low-income subsidy eligibility as a surrogate for economic status, we found that populations that qualify for the low-income subsidy did have lower measure rates. And in this case, it was again variable by measure, but for every measure, we did see that it was a slightly lower adherence rate. With all of these results that we've seen so far, if you look into the report, we have more discussion around the comparison of these results to other results that are out there in the literature. Generally, what we find is consistent with what we have seen. You can dig through the references and see some of those. Interesting here that we do see, I would say, a somewhat larger difference for the low-income subsidy status than we did either for age or for gender. I think there are factors at play that make that make sense, and some factors at play that would have made us think, and so at least some of us think, that the others might have shown more of a difference than they did in our findings. So as a summary for these socio-demographic factors, we called this out in the report that we're doing this within the context of CMS already having partnered with RAND to examine these effects on adherence. And they found similar to us that these measures were a potential target for SDS adjustment because there is a difference. We do see some differences, but those differences from the CMS partnership with RAND, as well as our results, are small, relatively. And that led to continued debate on SDS adjustment. CMS found and reported that most Medicare contracts would not have a change in their star rating using an adjustment model, and the results here in the PQS trend report tend to agree with those findings, that most contracts would not have a change in the measure level star rating as a result of a multivariable adjustment model based on the factors that we have looked at. However, that is to say, that's at this population level, that is at this data set. We recognize that there are differences, but when you pull out and look in the context of the star ratings, adjustment based on these differences that we were looking at would in most cases not make a difference. Moving on to the second chapter, which includes more analyses than the first chapter, as there's more things for us to engage with. There's more data types that are available for us to do some analyses. And again, utilization factors, we're looking at things like what medications are patients taking? Are they switching their medications during the measurement year? How are they getting their medications? And are they getting them as short duration fills? Are they getting them as extended fills? And as well, are the members that we're looking at, or if we only look at members who are retained in their plan versus members who are new to their plan, do we see any differences in correlation with medication adherence based on these questions? And additionally, we also looked at drug categories in the diabetes PDC measure, which is unique to that measure. We can't ask that question in the other measures, given that there are not multiple drug classes in the others. So for switching drugs within a measure, we'll start there. For the same reason, just as I mentioned, we didn't analyze diabetes PDC because a patient can appropriately be on or switch between multiple, more than one medication in a year. For RASA PDC and cholesterol PDC, we're making the assumption that a patient should only be on one of the medications that are on the medication list for that measure. And we did find that the measure rates were lower when including only patients who switched their target medications. And in other words, this was looking to see for patients throughout their fills for the entire year of 2022, for target medications for RASA PDC or cholesterol PDC, within that measure, did they have only one target medication? Or across their fills, did they have two or more target medications, indicating that at some point within that measure year, they switched medications within the measure. We hypothesized that we would see a lower adherence rate among those that had some kind of switching due to multiple factors that could be related to intolerance of medication and having to switch to a different medication, which also may lead patients to be less adherent even to the new medication, and other factors, structural factors, or just logistics of switching a medication, being clear about how to take that new medication, what might have changed from the prior medication. We also looked at distribution channel, and this is exceptionally simplified. We know, of course, that there are many nuances to distribution that we could have looked at. We looked specifically at those that were through a retail channel and those that were through a mail channel. More specific definitions of those are in the report itself. We found that mail was utilized by about 20 to 25% of patients in these measures. It did range a little bit by measure, but all of them were in that range of 20 to 25% of fills were through a mail channel. And the measure rates were higher for mail utilizers when compared to retail utilizers for all three measures. And you can see the difference reported in that rightmost column there here on this table. Related, I think, to the previous analysis is the question of extended fills. We wanted to see our patients who have, we stratified into three categories. Patients in a measure who had only extended fills, patients who had a mix of short and extended day supply fills, and then those who had no extended fills or only non-extended fills on their profile for the year. And that is the three categories that you see here stratified for each measure then across these 9 rows of this table. We found that the large majority of patients in every measure were receiving only extended fills. And then definitely the vast majority are receiving at least one extended fill if you lump together and sum the extended only, and then those who had a mix of non-extended and extended fills. And for every measure, the PDC rate was lowest for patients who did not receive any extended fills, and it was highest for the patients who had only extended fills. And the difference between the lowest adherence rate among these three categories and the highest rate among the three categories is fairly similar across the measures. We do see that the largest difference is from non-extended diabetes PDC patients to those who had only extended fills among their diabetes care. Additionally, I'll point out that the proportion of those among cholesterol and RASA PDC measures who only had extended fills was definitely larger. This was to us unsurprising because the mix of medications for diabetes PDC can be more complex, given that patients can be on more than one medication or medication class at any given time. it was not a surprise that the proportion of extended only fills for that measure was not as high as it was for cholesterol and RASA PDC. We also wanted to look at member retention, and we defined this as comparing patients or members who were new to a plan in 2022. So were they in the plan's eligibility in December 2021 and then new in January 2022, or at some time in January of the measure year of 2022? Or were they a retained member? Were they someone who had had eligibility with that plan in 2021 and then continued eligibility into 2022? We hypothesized that members that were new to a plan might have some barriers to adherence, but we were largely wrong. We found that there was very little difference with members who were new to a plan, though new members were slightly less adherent. So the question here, the yes category, is those that are new to their health plan. Encouraging, I think, to see that switching between plans didn't disrupt the patient or the care of these patients, and they were still able to achieve on a population level high adherence despite being new to a plan, and the confusion that we thought that that might bring that we could potentially see as being correlated with adherence rates. We also wanted to explore, knowing that there's a lot of overlap between the populations of these measures, what effect might that have? Let's say a patient is in all three of these PDC measures, these adherence measures. Does that mean that they are overwhelmed by the complexity or the relative complexity of their care, which might lead to lower adherence? Or does it mean that they are in the habit, they're in the routine, they're superstars in terms of taking medication and staying on top of their care, and or that they might be a higher priority patient for their healthcare providers to provide support and make sure that these patients are adherent because they have comorbidities? We found that there was a great deal of overlap in the measure populations. That was not really a surprise to us. We knew from our data in the past that there was a good deal of overlap, and others have examined this to some degree as well. We found that the greatest difference in rates is between the group that is diabetes PDC only and diabetes PDC rates for those who are in multiple measures. If you look, the population of diabetes only is reasonably small compared to the total population of the diabetes PDC measure. And their adherence rate was lower at 73.8%. When you consider those that are in all three measures, the diabetes rate for that group was 88.6%, which is one of the higher rates here. In all cases, just as it was for diabetes PDC, the lowest measure rate is for the patients that are in that one measure only. So interestingly, when we were going into this, we didn't know exactly which we would see, because we could think through reasons that one group versus the other, or if you're in only one measure, or if you're in all of the measures, that there might be reasons that it would pull adherence one way or the other. And as an extension of this, I find this to be a really interesting, it's one of the more simple analyses or simple visuals that we have in the report, but this I think is impactful. To look at patients that are in multiple PDC measures, specifically the diabetes PDC measure. There really is a relatively small proportion of any of the measures that is in that measure only, and that's particularly true for diabetes PDC. The majority of diabetes PDC patients are in all three of these adherence measures, meaning that they're taking medications for diabetes, as well as statins and RAS antagonists. So these are patients, potentially with metabolic syndrome that are getting a lot of care for these various comorbidities. And it's interesting to see that this is by far the largest category of this measure, is patients that are in all three of these measures. Gives a good picture for us, I think, of the patient population. Drilling also into the diabetes PDC measure, this is the one measure where we could ask this question, whether there was different adherence rates when we look at different medication classes. Unsurprisingly, metformin, which is considered its own medication class within the measure, was the highest patient count of the examined categories, with over 3 million, or 80.5% of the total is on metformin. Keep in mind, those percentages do not sum to 100 because patients can be on multiple or within multiples of these patient count being on multiple medications, and a large number of overlapping patients. We see that the smallest categories are GLP-1s and DPP-4s, but both of those do represent over 10% of the population. So this table is dense, and we wanted to provide the top-level analysis of what does it look like in terms of measure rate for these different medication classes, but also a sub-analysis of then breaking those groups out by low-income subsidy to see if there was anything to tease out as a secondary analysis looking at low-income subsidy across these various populations. So I'm not going to dig into the numbers here of the low-income subsidy side of this table and focus more on the drug classes themselves, whether a patient had a positive fill of one of the medications within that class, and then the measure rate. So really, we're focusing in on that center column in this table of measure rate and looking by class. For every drug or drug class, the measure rate for those patients who positively had a fill of the medication was higher, with the exception of GLP-1s, which produced the same rate. This is sort of unsurprising when you think about that the yes or no here is really not quite equivalent. The yes is saying we've definitely identified that there is this medication on board. And when you think through PDC calculations, a positive identification of a fill specifically, then that contributes to the PDC. So for all of them, when it is positively identified, it's no surprise that the measure rate is higher. But I do think it's interesting to see the various differences between the yes and the no category, with the largest difference or equivalent difference. Well, the largest is between the sulfonylurea, yes and no. Metformin is slightly shortly behind, and then GLP-1s do stand out as the one that doesn't have a difference between yes and no in this analysis. So in summary of the second chapter, measure rates are lower when including only patients who switched medications during the year. We talked through some of the logistical hurdle or challenge that switching might represent, and we believe, we hypothesize that is what's going on. Our numbers, of course, don't prove that. Secondly, measure rates were higher for male utilizers when compared to retail utilizers. And here again, I'll point you to the report that gives more detail in that analysis and definitions of how we bucketed those different channels. And then when stratifying patients by whether they had only extended fills really did make a difference or correlated with higher medication adherence. And there was a lot of patients within each measure, the majority, who had only extended fills on their medication profile. Interesting, whether a patient was new to a plan or retained from the prior year made very little difference. And then for every drug or drug class, the measure rate was higher for those who were positively identified to be on that medication other than GLP-1s, which showed no difference. To wrap up, what I see as kind of the top line summary here, or the takeaways, and split into the two chapters. Socio-demographic factors don't make large differences when considered at a population level. This is a very large population. Again, represents roughly 90% of Medicare lives. And that economic status may make a larger difference than demographics. I say may here because we're looking at low-income subsidy as a surrogate. Thinking through chapter 2, utilization factors, those can make large difference in measure rates, again, when considered at a population level. Extended fills only versus no extended fills was the largest difference in rates that we saw of any of these analyses. And then a large number of patients are in multiple measures. I have said, possibly on other webinars, or at least to my teammates, that we often forget or don't think directly about the people that are at the end of what we do, or the patients that benefit from, if we can be a part of increasing medication use quality, the patients are at the end of that and they will benefit from that. Keeping who those patients are in mind, I think can and should drive some of the things that we do and how we perceive the value of them. So keeping in mind that a large number of these patients are in multiple of these measures and have comorbidities is important context, I feel. And finally, again, the trend report is available. We published it on Monday. You can get it at our website, pharmacyquality.com. We'll be hopefully distributing a link in the chat for that as well. And you can go there to that kind of oval link there on the left-hand side. This is the page that will take you to, that you can download the report, read it in more detail. I hope that you will take a look at it. What I've talked through today is definitely the top line summary. I talked through a majority of the analyses, but there are additional details and other references to chase down in the report, which I hope you'll go and access. To wrap up, I really do want to say a thank you. This is a project that I lead, but it's many people. This is many people within PQS who have helped for conceptualization, review, analyses, deep data discussions, as well as external groups that have helped us with graphic design, conceptualization, and all of the other pieces along here. So I get to be the one in front of you to present these data and these results, but this is a team effort, and I'm very lucky to be able to lead this project year over year. We're already thinking about the 2024 report and excited about some of the things that we may be able to get into that report to contribute to the conversation around medication use quality. So I'm happy to be here today and talk through these things. And with that, Amanda, I will wrap up and pass things back on to you.
All right. Thanks so much, Andy, for that top line summary and analysis from the report. We appreciate it. I did drop the link to the report in the chat. So if those of you that are on the webinar would like to access it, please feel free to do so. We do have some questions coming in. So I wanted to remind the audience, if you do have a question for Andy, please send it to us using the Q&A feature, and we will address as many as we can. So the first question, Andy, is about the definition that you used for extended fills. Are you able to provide any clarity about what you had called an extended fill and how that worked?
Yeah, we typically define an extended fill as a single dispense that has a day's supply of 84 days or greater. We use 84 days for reasons that don't really hit these measures, but there are some medications that are on a 28-day fill, and then 3 of those fills would hit us to 84 days. So we've aligned internally around looking at 84 plus days.
All right, very good. Thank you. Second question is around the PDC analyses that you did. And this person would like to know if you did any of those analyses based on racial groups.
We did not. That is something that we discussed and that I would love to be able to contribute to. We didn't feel that we would be able to do that as well as we would have liked for this report and at the size of population that we wanted to. Certainly, we recognize that what we did for this trend report is a part of the conversation, and that another part of the conversation definitely includes a lot more socio-demographic factors that we were not able to analyze for this. So race or ethnicity were not included in our analyses.
All right, thank you, Andy. And actually, your response is a great segue into my next question. So you indicated that this is just part of the conversation. We also know that there's been a lot of published literature over the years on various aspects related to medication adherence and different factors that affect that. Can you give us an idea of like how the trend report fits in and the findings that you had fits into what's already been published and how it adds to that conversation too?
Yeah. Like is implied in the question, we're not the first, we're not the only, and we don't think ourselves to be the preeminent voice in this conversation. What we feel that we can contribute is the size of these analyses. The population size is uniquely large, and it gives us a window directly into the population. We could, if I'm critical of the inclusion, it's the data that are available to us. It is not the full population. It's slightly a convenient sample, but at 90% of the total population that we're trying to describe, it's very, we feel, has a lot of power to describe those differences. It is not research, capital R. This is not peer-reviewed research. but we want to be able to contribute to that discussion with the particular data set that we have.
All right, thank you. And actually, this next question gets to that idea of research and this being not capital R research. So you did not have any tests of statistical significance that were included, at least in the slides today. So did you include any of those in the report or otherwise? And if so, why or why not?
It was actually a question that I brought up at one point with some of our more statistically savvy folks of why we weren't including those. And essentially the answer was they won't mean anything, because the population is so large that any difference between different groups will be statistically significant. So really, statistical significant tests they're not really designed for something that does represent such a large amount of the population. So we chose not to include them because they wouldn't have added to the conversation.
All right, thank you for that clarification. Next question is, did you consider any other factors that could correlate with medication adherence that were not included in the report?
Yeah, we did. Through our ideation, there were actually some ideas that we were excited about that we just found we didn't have a good way to explore. One was that we hope to do in the future at some point is the effect of the regional adherence effect of something like a natural disaster. To see, say, a hurricane comes through an area, that's certainly going to displace some patients. It might change the way that patients are attributed around where they're getting their medications. It might change the channel that they receive their medications through. And that's obviously going to be a difficult thing in the lives of the people that are affected by such a disaster. And I can only imagine that it would lower medication adherence. That's our hypothesis. We didn't feel that we had a good way to isolate that or to find a way to answer that question very well. But it's in the back of my mind. It's something that we may want to explore in the future. And that's I think one example that was particularly interesting. There were other things that we had talked about that were very adjacent to the things that ended up in the trend report that might have just been telling the same story, and so we didn't pursue those analyses.
Always more analyses that can be done.
Yes.
All right. Why in this year's report did you not include any consumer surveys?
Oh, good question. So we trade off those every year, so or every other year. This was a year where we wanted to focus in on answering specific questions, but our plan is to return next year to our traditional structure, or how we started the report, of having surveys around medication use quality and the efforts that especially payers and pharmacies are putting into improving medication use quality, and then the consumer survey of patients about their perception of pharmacies or other groups as it relates to medication use quality. So that will return. We do plan to do that every other year.
Okay, great. Looking forward to seeing that next year. We just had a question come in. Actually, I think we actually answered that one already. So anything else you would like to add, Andy, to close us out here?
Only another plea to download, read the trend report. If there are things that we had great questions today. If there are things that you would have expected us to look into and we did not, we're always open to feedback. You can essentially email me at trendreport@pharmacyquality.com. Those go directly to me with any suggestions that you might have of things that we should look into in the future, or if there are I don't know, opportunities that you think that we would be particularly well suited to ask and answer questions. Always open to feedback, and hope that this report provides value. And if you find that it does provide value and you want to reinforce that with us so that we do those things again in future reports, please also email me at trendreport@pharmacyquality.com.
All right. Thank you so much, Andy. Appreciate you being with us today. As Andy said, feel free to share feedback with Andy and the PQS team via email. If you need help getting to PQS anytime too, we can always help assist with that. So thanks so much. I'm going to close with a couple of announcements today. So let me drop a couple of things in chat for everybody here. Just 1 second. All right, so first of all, just wanted to remind everyone, in case you weren't aware or just were curious, PQA is currently accepting self-nominations for our Education Advisory Council, and we are accepting those nominations through next Friday, December the 15th. This council is an advisory body that works with us here as PQA staff to provide us information, feedback, and recommendations on PQA's educational programming. And we have the council to ensure that PQA members have a voice in determining the direction of PQA's educational offerings. Terms for those that self-nominate will begin in 2024, and additional information about the council and about the self-nomination form itself can be found at the link that I posted in chat. And then also we have applications for multiple PQA student and professional programs that are now open. Applications for our APPE rotation, our summer executive internship, and our MPH practicum are due also next Friday, December the 15th. For more information on these programs, you can see the link in chat, and you can always email us as well. That email's in chat. It is education@pqaalliance.org. And then finally, thanks again to PQS for sponsoring today's webinar. PQS is grateful for the support. And then to all of you, thanks so much for joining not only today, but also for all of our webinars throughout 2023. We wish you a happy holiday season and look forward to seeing you back here again in 2024. Thanks so much for joining and have a great day.